And we want to know, hey, can this person who's had a stroke safely swallow and not put food in their lungs on accident because they just don't have the coordination yet. So there's a lot that goes involved into post-stroke care beyond what I do.
Hello, welcome to the Dr. Gill Show. This is where we talk about medical matters that matter to you. My guest today is Dr. Rafael Marroquin. Welcome to the show, Rafael.
Thanks, Gil. Appreciate it.
Rafael is a friend of mine. You are both a diagnostic and an interventional radiologist.
That is correct. Yeah.
Boy, what's the difference between diagnostic and interventional?
Well, it's interesting, radiology back in, it's been around for a long time. Back in the 60s and 70s, there started to be a push for image-guided procedures. And as technology has advanced, we're able to not only, diagnose your problems through a series of imaging. So whether it be ultrasound, X-ray, ultrasound, MRI, and then utilize some of those modalities to be able to then treat certain diseases.
To actually go in.
To go in, yeah.
Use those guided techniques to get. So that's so exciting.
We do get our hands dirty from time to time. We don't just sit behind the screen and just sit in a dark cave.
You're not sitting in the bat cave. We call it the bat cave.
Yes.
It's very dark because your eyes have to be dark adjusted to see the subtleties.
The worst thing you can do to come into a radiologist's room is flip on the lights. My gosh, it's like Dracula, getting exposed to sunlight.
So you're seeing patients, treating patients, intervening.
Yes.
Intervening. Yes. That's fantastic. Now, Rafael, you are one of the physicians and the director of radiology at a level 1 stroke center.
Correct.
Now, a level 1 stroke center, what does that mean?
Well, there's different designations that have been given to hospital based on their ability to treat stroke. So level 1 is about the highest certification that you can get, and that is the ability to diagnose and ultimately treat stroke. But there's a couple of different ways to treat. There's a level 2 stroke center, which you can diagnose, you can treat, and they're so-called the drip and ship. So we can utilize, getting a little bit technical, but you can utilize certain IV drugs to help clot bust stuff that's going on in the brain that causes stroke.
And get to the level 1.
And then get to level 1 where there are people like myself. There are other specialists that are able to treat this, not just interventional radiologists, but there's also interventional neurologists and interventional neurosurgeons that are able
to So it's a big deal. You got to treat a stroke quickly. You have to have a lot of resources.
Yes.
And I'm going to come back to this, Rafael. That's just fascinating. So I want to talk about you a little bit. Everyone has a interesting career pathway.
Sure.
And it's my understanding you are fully trained in internal medicine.
Yes.
You did a full residency, 3 years of residency, do internal medicine.
Yes.
So that's a real doctor. Stethoscope, white coat, all that kind of stuff. And then you started using internal medicine to work as an emergency room physician.
Yes.
And what happened? What light bulb went off, or what event happened that made you realize, gee, I'd rather be doing radiology? Tell me that story. That must be fascinating.
Man, well, I think I was probably 3 months into my internal medicine residency. And
oh my God, what have I done?
And you have this aha moment where you're like, did I pick the right specialty to go into? And
like when a date goes bad,
Yeah, exactly. It ends up being one of those things that, I loved what I did, but, one thing that I always noticed is that every time we saw patients, the art of, traditional medicine, of listening with a stethoscope and all that, was being superseded by imaging. And so at every turn, I was always ordering a CAT scan or ordering some sort of advanced test to help me figure out what was going on in my patients. And so I saw the radiologist as this guru of all of medicine that everybody came to. And I thought, what's that? And where is that interest of, being able to see inside the body and not just listen to it and not just listen to what's going on and getting these clues, but actually looking in and seeing, okay, that's exactly what's going on with the patient.
But you stuck it out through internal medicine.
Well,
You did all 3 years of residency?
I did, and in fairness, there was multiple attempts along the path to try to switch gears, and those avenues were not necessarily open at the times that I really wanted. But it actually ended up working out to my favor because I really learned a lot of clinical medicine.
It's a great
during that
training.
time.
I mean,
Yeah.
my goodness. I mean, you could argue internal medicine is good for everyone.
Yes.
And I think in the
Yes.
old days, you do a year of internal medicine or rotating internship anyway.
I think
no
that
matter
the
what you wanted to
internist
do.
is the doctor of doctors. I think that's the jack of
Yeah.
all trades. You know everything, and you're able to really understand physiology and pharmacology and how the interaction between disease presentation to treatment, and then you've got a lot of different pathways within that internal medicine to go in many different directions, subspecialized.
Sure, it's the foundation of medicine. So
Yeah.
we're working in the ER. I'm going to assume you got a spot in a radiology residency, and you took it.
I took it.
And then how many more years was that?
So after 4 years of med school, it was 3 years of internal medicine plus 4 years of radiology.
Then 4 more years of radiology.
So 7
Now,
years.
to make ends meet, were you moonlighting and stuff as a resident?
Let's just say that as you know, the modest, meager earnings of a
It's
full-time.
kibbles and bits. It's poor. It's slim
I
pickings.
think one of my residency colleagues actually broke down the math as how many hours we were working to what our salary compensation was.
Yeah.
And we were like well below minimum wage earners.
Way
well
lower than
below
minimum wage.
working incredibly tough hours. So, so I did do a fair at every opportunity that I got, whilst trying to not interrupt, my training. And at some point, everybody needs a little sleep. But the opportunities available to trainees at that time that's exactly what it is. It's moonlighting. You got to work at night and make a little extra dough.
Yeah, that's what I did in my fellowship. I was a fully trained OBGYN, but then I was doing my fellowship in reproductive endocrinology. Yeah. So any night I wasn't on call in my training, I was in the inner city, 10 miles down the street, delivering babies all night.
Oh.
Yeah, sleep wasn't a thing.
I don't know what that is. What is sleep?
What is sleep?
I think I'm finally catching up on that sleep lag,
Oh, man. So you did. And so during your radiology training, you learned how to read x-rays. They used to be films. You'd put them up on the light. They'd rattle. They were acetate films, and then they went digital. And then also in your training, you learned how to intervene, how to go in the body, guided by these x-rays and CAT scans.
Yes.
To do treatments.
So yes. Part of your training as a resident in radiology is doing interventional, and some people really take to it, some people don't. Again, that involves a lot of call, and some people are just sort of a little bit more averse to that. And coming from an internal medicine where I was always on call and always in the hospital, that just didn't seem that foreign to me. And I really liked using my hands. I was really
you're good with
accustomed
your
to do that.
hands. Yeah, a lot of doctors go into various specialties, and they don't have good hands, and that's that suits them.
Well, I tell my boys, I have 2 boys, 15 and 11, and my dad early on when I was growing up, what kid doesn't like video games, right? I mean, everybody likes playing video games, and so you get this hand-eye coordination, and I realized from early on that I had a pretty decent hand-eye coordination. And which, I struggle with now because my kids love playing video games, and I'm reverting back to my dad's old ways where I'm like, guys, enough is enough. Like,
you sound like your
is
dad now. Yeah, isn't that amazing? You sound like you say something. Hey, that's what my dad would say.
But then they come back full circle to me and pull a 180, and they're like, hey, Dad, but haven't you said something about hand-eye coordination? That's what we're doing. And I'm like,
that's
okay,
right.
well, okay.
That's right. And I do a lot of my surgeries. Once I'm in, I'm on the TV screen.
Yeah, exactly.
Yeah, so we're all doing that kind of stuff. So in interventional radiology, you can put little tubes or catheters into blood vessels, among other things. You can put them into abscesses and pockets and ventricles. I know you put things all over the body, but let's start focusing on the topic of today's discussion was stroke.
Yes.
You can intervene and treat strokes.
Yes.
So let's talk about what is a stroke, Rafael?
Well, so a stroke is, there are 2 types of strokes that people can have, and the overwhelming majority of strokes that people have are ischemic stroke. And what that entails, or what that means, is that basically an area of brain is blocked to blood flow. So,
all right, so there's blood. Our brain has lots of blood flow, crucial blood flow to work. It's very active. It needs blood, needs oxygen. And these blood vessels are susceptible to blockage.
Yep.
So a part of the brain loses oxygen, becomes ischemic.
Yep.
And then it stops working, right? So what are the signs? How does somebody know, I or maybe a family member or somebody I'm seeing on the street is having a stroke? How would you possibly recognize that?
Well, there's an acronym that came out that everybody might recognize, and it's sort of a 4-letter acronym. It's called FAST, right?
FAST. Okay.
So the first thing is face. You look at somebody's face. Droop. You're looking at a facial droop.
Okay.
You have somebody smile, and their smile is crooked.
And it's new. It's not their norm. It's a difference. Yeah.
Difference is new. The second thing, the A is arm. All of a sudden, you can't move an arm, or you're weak in an arm. All of a sudden, you go to pick up something and you drop it, and boy, you just can't get that to respond.
Oh, okay.
The third thing of the acronym, so FA, face, arm, S, speech. Our speech normally has a good cadence and a good rhythm. Slurred speech or unintelligible speech is another warning clue that's going on. And so the last thing is time. So time is going to be the critical thing. If you recognize a facial droop, arm weakness, or speech impediment, or a fall, or something like that, then time. So time is our critical factor. Time is brain. So the longer that a tissue goes without proper blood flow, the worse it's going to be. Now, in the brain, you've got a very limited window in which to act before brain tissue dies completely. And so time, that's when they tell you, call 911. So FAST, face, arm, speech, and then time to call 911.
And then time. And that's why being close to a level 1 center like where you work can have tremendous benefits, getting there quickly. Getting treated quickly. Is there a different type of stroke where it's not blood flow being blocked, but sometimes there's a hemorrhage or a bursting of a vessel or an aneurysm? Do I remember this correctly?
You nailed it right on the head. Like we said before, the overwhelming majority of strokes that come in are because of blockages, but there are those that bleed. So we can have a bleeding complication in the brain, and that can be as a result of your blood pressure being extremely high. Some of those little blood vessels, as we age, get a little bit more susceptible to pressure, and they rupture. Like a pipe with too much pressure will burst. That's exactly the same sort of analogy that I use. So that's one. Another one is that if we've got an aneurysm. So an aneurysm is a little outpouching, if you will, or a little balloon formation.
We call it berries, right? A little berry aneurysm. Yep. So it's a blood vessel, swollen area, and is that the weak spot?
And so then it becomes a weak point where that blood pressure is kind of hitting it, and it's susceptible to rupture. So, and then the third thing is, a lot of people nowadays, because of various health conditions, are on blood thinners, right? It's a very common thing now. And we've got new and developing and really good blood thinners to help things, but those can also cause some complications, and bleeding is one of those potential risks.
So are the symptoms the same, though, primarily? Like, I'm not going to be able to tell, Uncle Bob has a dry stroke, a blockage, or, oh, no, he's got a wet stroke because it's a hemorrhage. It's
a lot of times there is some differences. But
a person on the street, a lay person's not going to know, right?
A lay person wouldn't know.
We just know something's wrong with Uncle Bob.
Yes. Most of the time, a lot of people are going to present either the FAST that we talked about with the droops and so forth, but sometimes if it's a large enough stroke, people will be found down or collapsed or unconscious, and you won't know.
Obtunded. There's a word.
Happened. Yep, that's a good word.
Obtunded. So I came up with Uncle Bob. I pulled that out of the air. So Uncle Bob's there's something really wrong with Uncle Bob. And boy, it's looking like a stroke. So we call 911. Thank God willing, we have 911 where we live. Pick up Uncle Bob, take him to the level 1 stroke center. And he's coming in. Is he going to come through the emergency room?
Emergency room is going to be the first place. Some places, if you actually know that a patient is coming in, the ambulance people will do an initial, the EMS staff will do an initial assessment on the field And they've got, and it was really neat. The Neurology Association developed a stroke scale, and it's internationally been widely utilized. It's called the NIHS, the International Health Stroke Scale. And so it's a scale based on 11 questions or 11 assessment points with a total score of 0 to 42. And so based on that scale, they're able to tell the potential severity of a stroke, but they'll know ahead of time if they suspect a patient's having a stroke. Upon arrival, the first place they go to is my place. They go to CAT scan to get an initial scan.
All right, so the experienced EMT, the people on the ride say, "Hey, I have a patient here, blah blah blah. They've got such and such a score, highly suspect a stroke." So you're wheeling this person in the door of the emergency room, and they just waving you by to the CAT scan.
Yep.
So what does the CAT scan do?
The CAT scan, the initial scan is of your brain. And we'll get a little bit more into what types of CAT scans when we use that. But the initial scan that we do is of your brain without contrast, so there's no IV dye that's used.
And they can do that pretty quickly nowadays, can't they?
And our scanners are so quick that you're in and out within, the scan is done within 15 or 20 seconds.
Whoa.
So it's very quick.
It used to take forever.
So the technology it's amazing. So you can scan somebody's brain very quickly, and those images are then transported to us, and we're at our computer stations or from home now, or on my phone. There's phone apps that are connected that I can see. When a scan is being done, the neurology or the stroke team is alerted. They call me. I'll look at the scan, and what I'm looking for initially is the patient having a bleeding kind of stroke not.
And you can tell that from the CAT scan.
And that's
so your phone could go off right now.
Yes.
You could say, "Gil, wait a sec, hold on, I got to go to work."
Yeah.
You look at the phone, and you can tell.
Yes.
That there's probably a stroke and what type of stroke it is.
100%. Yeah.
Wow.
I'll even add another layer. I know we've got this new push. Everybody's heard of AI. What is AI? Artificial intelligence, and how does that apply into medicine? And so these companies are coming up with software, and it's already out there, and we use it actually, in which a computer is able to tell me with a high probability of detection, hey, this one has a high probability of having a bleeding stroke. And so I can see on my app, and right off the bat, it says the AI software tells me this person has a hemorrhage, or not.
And so it gives you a leg up. Obviously, you're going to confirm it and
Correct.
whatnot, but it points you in the right direction.
Correct. Yes.
Oh, my goodness. Okay. So Uncle Bob here has gotten a CAT scan. He's in the hospital, has gotten a CAT scan. A radiologist such as you, one of these specialists in radiology who's an interventionalist as well, finds out, gee, we have a blockage. We have a cerebral ischemia, and the clock is ticking.
Yep.
Where does it go from there?
Okay, so things start moving pretty quick at this point, right? So once we initially look at the patient, the neurology team is in the CAT scan room with them, and they tell me, hey, this person's initial head scan, or I tell them it's negative. Based on their symptomatology, the NIH stroke scale that we talked about, if it's
negative means normal.
Negative means there's no bleed. So if there's no bleed, then it takes us down a different pathway.
Now, most of them are these blockages, right?
Correct.
So let's talk about the common one.
So the common one. So now Uncle Bob has no hemorrhage in his brain, no bleeding in his brain. So we go down that alternate pathway. So then we keep him in the scanner, and we give him IV dye through an IV line that's been placed on the field by an EMT. And we're able to push this contrast. This contrast is a agent that I'm able to, that basically lights up the blood vessels so I can see the roadmap in the arteries in the neck and in the brain.
And is that through an IV in the arm?
Through an IV in the arm.
So you can get what's called an angiogram, a blood vessel image.
Yep.
Through an IV, so you don't have to put it in directly here in a carotid.
Yep. We now, technology has come such a way that it's standard now that you get a CAT scan and a repeat CAT scan now with the IV dye, and it gives us this, what traditionally used to be an angiogram where you had to poke the groins or poke the wrist and so forth. Now we can do it just through the CAT scan, and that gives me all the information I need as far as, are there any blockages in the neck that's causing this? Or is there a blockage in the brain or confirming our blockage in the brain potentially?
So you can accurately see where the blockage is?
100%, yeah.
That's amazing. What, were we talking 10 minutes, 20 minutes, half an hour?
So,
hour?
There have been some guidelines that have developed along the way as to, how quickly we want to treat patients, when they do the best, at what points in time. And so, the initial, we call it door to scan, we have a goal of 20 minutes, under 20 minutes.
So in the door of the hospital.
In the door of the hospital.
Not out of Uncle Bob's house, but he's hitting the door at the emergency room.
Within 20 minutes, we're getting the scans.
Wow.
Yeah. Within 20 minutes. And so within that time frame, I can then tell the neurology team, the ER, and coordinate between those different folks. I do identify that there is a large enough blockage in the artery in the brain that I can go after to treat it.
All right. So Uncle Bob's got a blockage. Rafael, you're in your scrubs. You're ready to go. What happens next?
Good question.
You're not going to do that in a room in the emergency room or on a stretcher, are you?
No. That then, as you alluded to before, requires a very specialized team. So I've got to bring in, the stroke team, and that entails nursing staff, interventional radiology techs,
and they're on call. They're ready to go.
On call, ready to go. We're on call 24/7, and we're within a 30-minute response time of when we get the green light that there is a stroke for us to intervene on. We're in the hospital and, trying to get the patient on our special table. So we have a room within the hospital that has special X-ray equipment that allows us to perform this procedure. So we bring the patient back to our suite.
It's the suite. So in the suite, special tables, special radiology stuff. I've seen it. There's boards and special lead line windows. So you scramble the team, you get Uncle Bob to a special table. Now, is he sedated? Do you need anesthesia? Do you relax these people? Or obviously, if they're obtunded, you're not going to need anything. But you have to how do you physically start treating a person? They must be scared. Their things aren't working. Tell me how. What does it look like? One of these when you take somebody to the suite.
It's very scary. I usually see these folks in the ER as soon as they get their scans, talk to family, let them know what's going on, expectations of what is to come, what options we have, how to proceed. And so it's a very scary moment because we've got to make very quick decisions about how to get going and when to get going. And it can be a very trying time. Patients a lot of times are, as you said, obtunded, confused. They don't know what's going on. Some of them, depending on where the blockage is in your brain, can affect certain things. And so some people can be very coherent and they know exactly what's going on. And it's a very scary time for them. And so in short, to answer your question about, how do we get going and treating and sedating and so forth, depending on how the patient presents, very obtunded, very confused patients that don't know what's going on, my preference is to do an intubation. And so, to get these folks on a ventilator so that we can do what we need to do without any motion. And
so you need anesthesia.
So I do need anesthesia.
Is that a nurse anesthetist or an anesthesiologist? Or
well, the initial algorithm we've developed is if we need the patient intubated, the emergency department team intubates the patient, and then we have respiratory therapists and specialized nurses that then assist us in monitoring the patient while we're doing our procedure.
So an ER physician is perfectly qualified. An intubation means putting a tube generally in the mouth and go in your nose down into the windpipe.
And the windpipe.
And breathing for this
artificially
person.
Breathing, yeah.
So they need to be generally paralyzed or very relaxed or very anesthetized for that. So now you have an intubated patient. They've come up to the suite. They're ready to go. Now and you've identified, what is a typical place to find a blockage, Rafael?
Yeah, so the brain has a very interesting, complex highways of carrying the blood. One of them goes from the back of our brain that feeds the back part of our brain, and a large part of it goes through the front, through the carotid arteries in our neck that feeds the front and the majority of the brain. And so the majority of the strokes that we encounter that are blockages are from what we call the anterior circular, the front part of the brain.
These big carotid arteries that come up,
and they
split,
feed the brain.
And there's one that feeds straight to the brain.
Yes,
right?
Exactly. And there's multiple pathways that then break off and branch off. But what we would call a large vessel occlusion would be one of the large main arteries within our brain that gets occluded.
Is that one of the more typical?
Yes.
Bread and butter, run of the mill, you
Yep.
see all the time.
Yeah.
So now you've identified through the CAT scan where the blockage is and what you think it is. What does Dr. Marroquin do now?
Well, that's where the anxiety starts. You know.
Yeah. Yeah.
There's always a little puckering.
We're getting serious now. Yeah. Yeah.
So that's where things. That's where the skills and training and. That's where that comes into play. The next step is once our patient is on the table, the next step is putting a series of tubes we call catheters in the artery in the groin.
All right. So the blockage is in an artery.
Yeah. It's counterintuitive, right? You think, how do I get this out? Where do I go from? What pathway do I go from?
So you can go in an artery in the groin. I'm trying to think of the anatomy here.
Yeah.
So there's the big, huge artery from the heart called the aorta going down here.
We in interventional, we like to call it big red.
Big red. I know there's big blue and there's big red. So big red. You can get into a femoral artery here, I assume.
A femoral artery.
And you can get a tube, thread it up, this catheter.
Yes.
And you're getting up to the arch of the aorta.
Yes.
Now where do you go?
Well, so
how do you know where to go? There's all these different branches.
So much like the dye that we use to initially diagnose that goes through, we inject that dye in through that tube that we've got, and that helps us sort of light the path.
So you can find the right vessel, the correct carotid.
The correct carotid.
So then you're going north.
So then I'm
through
snaking,
the carotid.
Yes. Yeah. So then I'm snaking that catheter over these. We call them wires. So if you look, if you think of a wire being strands of hair, thickness of strands of hair, those wires are stiff and they help us guide our path up into where we go. And over that wire, we snake that catheter up into where we need to get it.
So this just I'm getting all anxious. I'm the pucker you're talking. I'm getting all anxious just thinking about this journey. So you've got this catheter, you've snaked your way through it, you've gone up a carotid.
Yes.
And you're up in the brain now.
Yes.
And you can get to the blockage. Now, is that usually a clot or a plaque that broke off? Is it usually a blood clot?
It usually is a blood clot, a plaque that broke off. Most of the patients actually that we see are patients that have had atrial fibrillation. That's a quivering or abnormal heart rhythm that most commonly a lot of people have.
We see this I see the ads for it all the time. Famous celebrities. I think I just saw Abdul Karim Jabbar talking about his AFib.
AFib. And so what do you do for that? There's new therapies that are emerging for that, but the mainstay that has been is anticoagulation. Now, when these patients sometimes are not anticoagulated or have not been diagnosed formally with this AFib, you can throw a blood clot from your heart.
So the heart isn't contracted, the blood is pooling, creating a clot.
It clots.
And that clot can break off and go up into your brain. So that's the most common presentation.
Yes.
All right, Rafael, you've gotten a wire and a tube up there. It's still their blockage. How are you going to get this blockage out, or what are you going to do about it?
Yeah, that's where it gets a little bit challenging. We end up identifying that on X-ray, that we're doing live X-rays that we're doing and guiding our catheter. Once I identify
you're there,
exactly where we're at, all of a sudden picture a freeway that is, you got a wide open freeway and you can see for miles ahead, and all of a sudden you get to a point where there's a bunch of traffic and everything's just blocked. That's exactly sort of what it looks like. Is you lose that clear freeway and you all of a sudden see backed up cars. That's your blockage. That's your clot. And so what we do is there's two different ways that we take these clots out. The initial way that people developed is with stents. And so what we would do very early on is through that little tube we would deploy a stent, a oh gosh, how would I describe this?
A springy cage, maybe?
Yes, that's a perfect way to
So it
describe
goes
it.
in
Yes.
skinny and then it springs open.
Yes, it springs open. And so what it would do is, you picture a hole that springs open, compresses and traps that clot.
Okay.
And then you pull that cage out and hope that that clot comes out with that cage in its entirety.
Oh, you're pulling the cage out. That's kind of gripping
the clot, pulling it out with you. Well, somebody pretty smart came along and then said, well, wait a minute, there could be a better way. So why don't we just suck this thing out, And so instead of using a cage to grab this, well, you already got a tube up there. Well, can we just pull back on that tube, create suction, and aspirate that clot? And what they found is that was actually pretty darn good and as effective, if not in some cases better initially, than pulling it out with the cage. You can suck this out or aspirate this clot out. And technology over time has gotten better and better, where now we've got pumps that are electronic that regulate how much pressure they're pulling and sucking back based on how much clot there is, or the sensor is detecting at the tip of the tube.
Sensors. So you go up, you suck it, then how do you get the clot out?
So once if you suck that out, it's stuck within that catheter. So then you maintain suction or aspiration, and you pull the catheter all the way out of the body into the groin, out of the groin.
And you can pull the clot out the groin.
And
but how do you get back?
Well, you actually asked some good questions.
So how do you know you got all of it?
So that's good. So I have a series of tubes through which I work with that. You start out big and they get smaller and smaller. It's kind of like those, Chinese or Russian dolls that, that you open up one, another one pops out, you open up that one.
The Kachina dolls or whatever they are. Yeah, they're nested.
So that's what we do. We have a series of tubes. So we use the smaller tubes to pull out. We maintain a larger bore tube.
So you keep the big one there, using the little one to suck out the clot.
That's exactly right.
And how do you know when you got it all?
Well, two things. One, the clot will get pulled back, and you can actually physically see the blood clot in your in your suction canister, that there's, return of that. And two, every time I go and try to do a pass, we call it a pass, when you go and try to retrieve some clot, we do a run, we do another roadmap or another angiogram. And then we're able to see, did we effectively remove all the clot?
And you can restore blood flow, and you can see restored blood flow. And you can see
restored blood flow pretty neatly. Yeah.
Wow. How long does it take you to remove a clot here in Uncle Bob with an AFib clot that you usually see? What is that?
That's a loaded question.
Or what's the range?
And so the loaded question, the reason why I say loaded question is because not every anatomy is created equal.
Oh, I know. There's all these variations. I'll explain to people. There's this artery circle in the brain.
Yeah.
So if you get a blockage here, blood should be able to come over here.
Yeah.
But not everybody, the circle of Willis, not everybody has a full circle of Willis.
Yes.
So some people have what's called collateral flow and some don't.
And you throw in another curveball here. Not all clot is created equal.
Please explain.
So, we have fresh clot, we have old clot, we have hard plaque, soft plaque.
Oh.
And so all these different things can contribute to the degree of success that you might have in completely removing that. And sometimes that fresh clot or old, it can fracture as you're trying to pull this out.
It sounds like you'll shower. You can break it off.
And you can break it off, and it goes further out. So, there's always that initial moment of puckering.
Yeah.
Well, actually, you're puckering the whole case.
The whole case. Yeah. Because somebody's brain's on the line.
So
the clock is ticking.
And the clock's ticking. And so, there's always that moment of puckering when you first do your initial first pass that we talked about, and you remove something, and you go and do the angiogram, and you're waiting to see, is it fully open, or is there still some left behind, or did I inadvertently did it break off and it went now further out, and now I'm going to have to go in and work a little harder to try to get as much as I can out.
So it's
a loaded question. So
what's the range in time? Give me a range.
If everything works the way one.
What's an easy one?
20 minutes.
20 minutes.
20
and if
minutes
it's
from
breaking off and showering and resisting and stuff's just not working out right.
Well, I'll tell you, after about 3-4 passes, I think the more time you spend trying to do that, you can also have some potential deleterious negative effects where, blood vessels do get traumatized and you can inadvertently cause a complication. So we never want to cause that, obviously, but you want to know the limitations of what you're able to do and how much.
So how long? Okay, I gave it all she got. I mean, that was our previous interview with a neurologist. Give it all she's got.
Give it all.
So after 3-4 passes, you're done. What would that take? Like an hour?
So usually, most I've done. I think my rule, and this is me personally, is if I'm spending more than an hour on something, your complication risk starts going pretty exponentially up. So about an hour is, if I've done all I can. Trying to pull the clot out. Now, if it gets showered more distally, we've got one more trick up our sleeve. Sometimes our tubes aren't big enough, are too big to go after these very small areas. So we've got one more tool in our armamentarium, right? And that is what, people may have heard of, this clot busting medication.
That was my question. When do you call in the clot busters?
So
who are you going to call? Clot busters.
Yeah. Call me. I tease. I'm a clot buster plumber. I'm a plumber clot buster. But so early on, if it's determined that we start getting into some technical stuff here now, depending on when you are having your stroke and how long it's been since you've had a recognition of your first symptom. We've got a time frame, and the magic hour, and through lots of studies that have been done, is 4.5 hours. That's the magic window. 0, when you first present with symptom, to 4.5 hours. That is the optimal window to get in, because we can do this clot busting medication through the IV before we even get started with anything.
Wait a minute. So you can give the clot buster and then put the catheter in?
Yes.
Because I thought with heart attacks, once you gave, which is kind of an analogous thing, it's it's an occlusion or ischemia of the heart. I thought once you gave a clot buster for heart attack, you couldn't go in there. That was it.
Yeah. No, this, fortunately, we don't wait whether the patient is a candidate for doing a procedure that I do, we call it thrombectomy. Whether they're a candidate for that or not should not preclude them and would not preclude them from getting the clot busting medication if they meet the criteria. And there's a separate criteria.
All right. So you've determined this is probably a blood clot.
Yep.
Is a good candidate for a clot buster. What was it? It used to be called streptokinase.
Yeah,
they still use that stuff, or do you have a fancy biotech version now?
Yeah, now it's changed, and since my practice, it's changed even yet again. But it changed from that to Alteplase.
Alteplase, okay.
And now we're using another variation of that is called tenecteplase, and that's sort of the newest one that we've used. All these have been around for a little while. But now, as new studies come out, dosaging gets a little bit better, easier for clinicians to use dosaging. You start moving away from one and going towards another for ease of dosing, better efficacy, etc.
I love armamentarium. I love that word. So the armamentarium continues to improve, and you're making incremental improvements.
It's one thing that I love about medicine, is that we're never a static field. There's always something, what stays constant is anatomy, right? We know anatomy, we know disease, but what changes, and what I love about radiology, especially interventional radiology, is there's so much innovation. 20 years ago, if you would have had a stroke, our armamentarium is limited. The technology that has gone in to developing these tubes and these medications and these things that I use has incredibly expanded to now before you were limited to maybe just getting the clot busting drug through the IV. Now we're able to not only be able to potentially, drag that out with that cage, suck it out or aspirate it, and also, if need be, give medication directly at that blood clot that can help break it up when I'm not able to pull it out.
You don't have to give it in the arm. You can give it directly.
Yep.
High concentration where you want it.
Yep. Smaller doses, but still high concentration directly at the clot.
That's what I seem to remember.
Yeah.
Now, let's say we have one of these wet strokes where it's a hemorrhage, something is burst. Can you do something about that, Rafael?
In some cases, yes, and I'll explain. So, if it is determined, and we use, again, imaging is really the mainstay of a lot of this, right? And the technology has advanced, and so we're able to do these CAT scans much quicker. We're able to do these angiograms of the brain with our CAT scans. If we are able to detect that there is one of these aneurysms, these berry aneurysms that we talked about, that has burst, and there's a typical pattern of what I see when an aneurysm bursts, a typical pattern of bleeding. And if I detect that and we identify an aneurysm, then we are able to do a very similar thing in which we take the tube through the groin, but rather than put a cage or aspirate or anything like that, now we need to stop blood flow to that sac.
Now you need to
that's
stop
ruptured.
the blood. It's completely different
different thought process. Yeah.
Now you want to make an occlusion.
So now I want to occlude that.
Tell me, how do you do that?
Yeah. So we've developed, and I say we because as a community, we've developed through industry really neat we call coils, and these coils look like, again, if I use the analogy, strands of hair. They're about that thick in some cases and different lengths, but we're able to put a little tube into the sac that's the aneurysm, and once the tube is in the sac, we're able to deploy these coils, and these coils, as their name says, they coil in that sac, filling that sac so that no more blood flow gets into it, and therefore stops the bleeding.
Do they promote clotting? Do they have clotting factors or irritant, whatever you would call intrinsic, extrinsic pathway you're getting out of my knowledge zone here? So that can they start a clot to form there and make your occlusion? Is that how they work?
So we've got stuff that we use in the brain, and we've got stuff that we use elsewhere in the body to do the same effect. Now, not all coils are similar. You're right. You hit the nail right on the head. So certain coils that we use, not in the brain, have fibrin little strands on them that promote coagulation or blood clotting. In the brain, we don't want to use that because we only want to coil what's inside that blood vessel without any risk of clotting the parent vessel or the feeding vessel to that, because then that'll cause a blockage stroke.
Right.
So
you don't want to,
we don't want to cause that too.
Right. Create another problem. So you can coil a bleed and stop it and slow it down. Now, if it's a bad bleed, is that when you have to call in neurosurgery? The neurosurgeon's got to go in this way?
Yeah, so bad bleeds, depending on the location, most of the aneurysms that bleed are able to be treated endovascularly or within the blood vessel with tubes and wires like we just alluded to. There are occasions where those blood vessels are just not amenable for us to treat. And so a neurosurgeon then steps in, and they have their ways of treating them. They can clip them and so forth. And that's where they get involved. At Boone, we actually, we do these cases in conjunction with a neurosurgeon. So we're both involved in treatment of these.
And you can tell them exactly where it is, so they know where to go.
And they know exactly
So you're still tremendously valuable
in
this treatment team. Well, that's fantastic. Okay. So Uncle Bob has had his clot sucked out. He's out of the suite. I assume he goes to an intensive care unit or something. Where does he go now?
So he goes to the intensive care unit, where a team of stroke team will then start the process of the potential long-term process of evaluating what is going to happen. The strokes have an evolutionary process. So, where the initial symptom might have been, if Uncle Bob came in with the big clot that we took out, and his initial presenting symptom was inability to move half his body, then we're going to see over the coming days how that stroke is going to affect the brain long term.
So they don't just wake up fine. I assume the brain's got to reperfuse and heal,
reset a little bit.
And it's going to swell. And it just sounds to me like it's a long recovery potentially.
It could be, potentially. And so, then this starts a little bit more investigating. One of the things that is always done is you get a follow-up CAT scan and an MRI. The MRI is going to be very sensitive in telling us exactly what area of brain ended up having an infarct, if at all.
If at all.
If at all. And I have had, obviously younger patients have a lot more collateral blood flow, and so they tend to do much better than old patients. But it's very rare for a young patient to have an occlusive
stroke. Interesting. Yeah. Now, are there times when you've just cured somebody, they go home in a month or two later, they're back to as good as new?
Yes.
Is that so that can happen?
It can happen.
So you can totally virtually cure somebody after one of these strokes.
Yes, 100%. 100%.
Wow. How often does that happen? 5%, 10%, 50%? What are we looking at?
Boy, within my practice, our neurology team is the folks that end up following the patients long term. So once we do intervention, I don't necessarily have that long-term follow-up to give you that data.
Gotcha.
But I will say that based on studies that were done in the late 2000s, we showed that by being able to do and remove these embolic strokes, these clot strokes, that we were able to get patients, 50% of patients, at least 50% of patients, back to a very functional status.
Okay, so it's not like a death sentence. Gee,
Yes.
Uncle Bob here, he's got it. If you caught it in time, and he's not super old with other problems and whatnot, there's maybe even a 50% chance that he's going to be virtually cured.
That he's going to go back to living a very functional
life,
pre-stroke life.
That's amazing. Now, obviously, if it's taken a while and there's more complications, you can have prolonged and permanent injury.
Yeah. And those take a little time to sort of tease out. The brain, once our patients go back up, if they were intubated for the procedure, it takes, the following morning, the following day, the ICU team works on getting them, off the ventilator, out of the breathing tube, and then start assessing what is sort of, residual infarct, what's going to be affecting them. And then you start getting physical therapy involved. You start getting speech therapy involved. One of the big important things that is done afterwards is, and one of the first questions outside of stroke care that patients always ask me is, hey, doc, I don't care what you're going to do to me. When can I eat?
You're right.
When can I eat? You told me to not eat after midnight, the day of my procedure. It's 2 p.m, man. I want to eat. So, that's an important thing. And we want to know, hey, can this person who's had a stroke safely swallow and not put food in their lungs on accident because they just don't have the coordination yet? So there's a lot that goes involved into post-stroke care beyond what I do. That we have an excellent team that transitions to that.
Fantastic. Now, my mother-in-law lives with us, and she's in her 80s. And she said, make sure you ask him, how do you avoid a stroke? Now, because in her family, I can say this, they have aneurysms that run in their family. I don't think there's anything you can do about an aneurysm you're born with, right?
Well,
other than keep your blood pressure down.
Well, that's a very good point. We do, if there is a familial or family-related known history of potential aneurysms in the family. So early screening, screening for any aneurysm with CAT scan or MRI.
You can screen for these things.
And so you screen for them.
So if you have a family history, you can say, doctor, into your internist.
Yep, I have a family history.
And there is a screening protocol or whatever.
And we routinely do come across our desk, routine screening MRIs to look for and or exclude aneurysms. And should we find one, then we refer those patients to the neurosurgeons, and they get appropriate follow-up based on size. There's some size criteria, but these can be treated before they go on to burst.
You can nip it in the bud. Very good. Now, I don't want to get into the huge topic of vascular health.
Sure.
Because we've had terrible advice for 50 years on how to eat for vascular health with no good evidence. But without getting too specific, is it fair to say that good vascular health will lower your risk of stroke? Is that a fair statement?
100%. 100% fair statement. I think that, as we routinely do more and more imaging for other issues, we find that that you have people have plaque in their carotid arteries or in their heart or in their aorta that can predispose to deleterious effects in our health, be it embolic strokes in our brain or in our legs, things like that would then severely limit our ability to do our daily dating.
So healthy blood vessels should lower your risk of stroke. That's a fair statement.
Fair statement.
Fantastic. So try to avoid smoking, avoid damaged fats.
Yes.
And, I'm just going to leave it at that because, like I said, advice is, let's say, evolving.
Evolving, yes.
Kicking and screaming, people are finally being brought to the truth.
Early screening. So you're internist.
Very good, Rafael. Well, Rafael, what an interesting talk we've had. I would love to have you back sometime, and we can talk about all the other places you can put these catheters in the body.
Gil, that gets me going, man. There's a lot of cool stuff that we've done, a lot of cool tech that has developed. Yeah, I'd love to do that.
I'd love to talk about other things you do in interventional radiology. Fantastic. Well, Rafael, once again, thank you for a great talk. What a pleasure it is to have you as a colleague and a friend in the area. And kudos, man, for such incredible work that you do at this Level 1 Stroke Center.
I'm blessed. I'm privileged to be able to do this sort of work. It's a gift to be able to help people and see that long term. If I can give you a little side note,
I would love to hear
a little personal anecdote. I met an interesting. I had an interesting person. One of my most memorable. Every physician that you'll ever talk to always has one case that they remember or something, whether it be good or bad, and we all have those. And I was fortunate enough to be able to treat a young lady, and I have her blessing, if I can. And
permission to talk about her.
Permission to talk about her. I treated her stroke about 4 years ago, and it's a young woman, is a very vibrant young woman, beautiful young woman, in her late 30s, and ended up having one of these occlusive strokes. And she came to our facility. It was a Friday night. I remember very well because
it's always the worst time.
It's always worse.
Friday afternoons and nights. Oh.
And the ping came to my phone, and I was with my boys, and it was one of those things that's like, Dad's got to go. Dad's got to go. So I went in, and what struck me was very few 38, 39-year-olds have strokes, to this degree. And within that 20 minutes, that clot was out, and she made an incredible recovery. You asked earlier about, how many people, come out doing well. And I can tell you initially, after talking with her, she had some initial sluggishness and initial, tired. She was tired. I think that's the brain's way of sort of rewiring, resetting after a big traumatic event like that. But 4 years later, she is doing fantastic. And we're going to get married in July.
Oh, that's so heartwarming. Yeah. That's fantastic.
So she is an amazing person and has taught me a lot. And I would have never pegged that, but I was fortunate enough to be in a place at the right time, at the right place, and so she's made an amazing recovery.
Congratulations. Oh, doesn't life work in mysterious ways?
In incredibly mysterious ways, yeah.
Well, Rafael, thank you again so much for taking time to talk to us today.
My pleasure, Gil. Good to see you. Thanks.